Brilliant. Hello, everybody, and welcome to this month's Value-Based Healthcast. I'm David Hanna. I'm a doctor. I work in Cardiff.
And I'm Dee Lowry, and I'm Head of Value-Based Healthcare at Clontarf Magog University Health Board.
So welcome to everybody. For those of you who are new to the Value-Based Healthcast, this is a monthly session on value-based healthcare that we deliver to you in conjunction with Professor Sally Lewis and the Welsh Value and Health Centre. And we're in part 2 of a 3-part series on outpatients. And Dee and Dr. Nick Wilkinson were delivering last month's session, which was on outdated outpatients. And how did that go, Dee?
Really well. So if everyone remembers, we had the horrible history. So we took a journey back in time with Sally Lewis to see where did outpatients begin and where have we been headed. And then we had a great presentation from Will Oliver talking about the 3 Ps. So prevent, promote and prepare. And this session now, we've got a bit of a roving reporter approach to it. So you'll have to bear with us. It's a new approach. But we've been out and about in the fields talking to a number of fantastic clinical teams who have been doing things slightly different.
Yeah, intriguing. So the first session is going to be delivered by Dee, and it's a recorded session. So although the team who record the session aren't delivering it live today, they're hoping to join online. So we really encourage everybody to pop questions in the chat bar as we go along, because actually, as I said, members of that team are going to be joining us online. So either Dee or myself or members of that team should be able to help answer any questions.
And we've also got the privilege as well, just in case the clinical time runs over, because we know it can happen. This is real world life. They have all agreed that if they aren't able to join us today, we can take additional questions back to them and we can make sure that they get out to our viewers. So yeah, please do participate. Anything you think of as you're watching the videos, pop it in the chat screen, just in case we miss those questions, Dave, because it's the first time for both of us. So I had the pleasure of interviewing Muthu Ganapathy up in Betsy Cadwallader University Health Board. And Muthu is a consultant trauma orthopedic consultant. He's a specialist in hip and knee, and he's also the arthroplasty lead and the teaching lead at Betsy. So we're going to share the video with you now about the fantastic work that they've been doing up there. Okay, we're just pressing play behind the scenes.
Any second now. Get your popcorn ready.
So virtual joint school prior to hip and knee orthoplasty, looking at the patient feedback and the carbon footprint savings by this method. Preoperative joint schools are very important for good outcome after hip and knee replacements. They give better understanding of surgery, decrease anxiety, improves postoperative pain relief, minimize length of stay, and decrease readmissions. Even the Royal College of Surgeons suggests that such surgery school should be a norm for all major surgeries. The traditional joint schools are usually face-to-face. They are essentially didactic in nature, probably lasts about an hour and a half to 2, and too much information is given during the session. There's a lot of travel involved for the patients, carers, and it's quite time-consuming for them and also our MDT team as well. After the COVID, everything stopped, as you know. So when we restarted our elective work, we had to think of what to do as still social distancing was in place. So we thought about doing the sessions as a virtual model. So virtual joint school consists of 2 parts. First part is online educational videos. The second part is virtual interactive group clinic. Basically, all the patients coming for pre-op assessment, at that stage, we ask them to attend the virtual joint school. They are sent information to look at the online videos and then invited to join the virtual group clinic a couple of weeks later. So if you look at the online videos, a lot of work put by our NDT team. We created a lot of useful videos for hip replacement, knee replacement, as well as day surgery, hip and knee replacement. For example, this all could be found if you search for aesthetic with a joint school in the YouTube. So if you look at hip replacement, for example, there are a lot of videos There is a lifestyle program to lose. This is a program to lose weight before joint replacement, and getting match fit, how to optimize your health prior to surgery, and hip replacement, your journey explained, about anesthetic exercises, all those things. Same thing for the knee replacements as well. And when you look at day surgery, hip and knee replacement, which you're doing in Bangor, so the patient goes home within few hours after a major surgery like a hip or knee replacement, put a lot of information on that, like introduction, overview, pain medication, and also we put patient videos as well. You can see the last one is a fly on the wall documentary about a patient who had a day surgery knee replacement. It already has 11K views. People find it quite interesting. So the patients look at the videos along with the carers, then they're invited to join the virtual session. Usually it's done every week now, and usually it has 8 to 10 patients, and they come with a relative or a friend, and they interact with our MDT team, including the nurses, physiotherapists, occupational therapist, orthoplastic coordinator, and also often a former patient with a lived experience. Essentially, this is a completely different format from the usual face-to-face joint schools. It's not didactic because the patient would have got all the information. It's more about interactive session if they want to clear any doubts and that sort of thing, and not lectures. So we wanted to see the impact of our model. First thing was about the patient feedback, and we did it by a prospective electronic questionnaire. And the second one was carbon footprint saving. This we calculated by the travel miles and time saved. This was done using Python software. And between July and 2022 and February 2023, 267 patients attended the virtual joint school. So this feedback is from those patients. Now more than 500 patients have attended already these joint schools now. So we asked about the YouTube videos, and you can see 89% of the patients felt they were very useful. And the interactive session nature of the virtual joint school, we wanted to assess, and we asked whether the concerns were listened to, and 94% agreed. And we also asked whether they had opportunity to ask the question, and most all of them, like 97%, felt that they're given the opportunity to ask questions. So the patients were quite interacting. And interestingly, we wanted to find how they're accessing these videos and online sessions. And because most of our joint replacement patients are elderly patients, and you can see 65% of the patients had support from family and friends. There's a big advantage in 2 ways. One, they are becoming digitally empowered, all these elderly patients. Number 2, the relatives or carers are also taking part in the pathway of hip or knee replacement. And we also asked about the preparedness for surgery. So after just the passive online videos alone, the preparedness for surgery improved to 6 out of 10. But after the interactive virtual session, it improved to 9 out of 10. Basically, all the patients are well prepared for this surgery. It's very, very important. That's showing the importance of the virtual joint school. We also asked the patients what they want to do if they have to choose again, and 86% of the patients chose virtual joint school as the model they would like to attend. And we also asked subjective feedback, like a lot of good comments. Most of them are positive. This is from one patient. The experience was great, knowing that others were in the same situation and I was not the only one. Different people in the class had different questions I had not thought about. So between the class, a wide variety of questions were put forward, making it a very informative session. I felt it gave me a real connection with the forthcoming procedure. This is the future, and we should, when having appointments, or actual face-to-face is not necessary, saving both the client and the hospital staff time. It was reassuring to hear from the other patient who had similar concerns, and from one person who was very positive about her previous experience of surgery. In fact, we even convinced patients who were skeptic about the joint school. This is the comment from one patient. I was expecting a boring 2-hour lecture on knee replacement. I was pleasantly surprised by the friendly manner in which the session was conducted. All questions were answered in a friendly manner with a strong knowledge base without using technical terms. When you look at the time saved, average was saving about 62 minutes per patient, and that doesn't include the time spent to find car park space. And if you look at the distance saved, average 38 miles saved for each patient. And in total, for this group of patients, we have saved more than 10,000 miles of travel journey. Now, if you convert into carbon footprint, if you look at a traditional face-to-face model for a one session, the carbon footprint will be 91 kilograms CO2. With the virtual model format, with the same sort of patients, it is only 0.32 kilograms of carbon dioxide. It's a big saving of carbon footprint. So we also feel that it's better to introduce them to the online videos much earlier rather than just at the time of the pre-op assessment. So we started giving cards like this when we list for the patient, so they can start looking at the videos where there is a discussion about optimization, stopping smoking, all those things are important things are there. And there are also these notices there in the clinic spaces as well. So the patients are aware of this. Now, future plans, now that many patients are digitally empowered, so we want to put further videos like waiting well, that is pain management, while on the waiting list, probably considering virtual orthopedic rehabilitation, and perhaps even digital consenting. And obviously, this will help in collecting of digital prompt collection and follow-up as well. Thank you very much.
That's perfect. Thank you so much, Ruthie. So much to unpick there. I think what you've been able to sort of pull together with all of those different interdisciplinary teams participating is absolutely fantastic. So I've got some questions,
Absolutely.
so if that's okay. So my first one was, how many of your cohort of patients do you think were able to virtually access compared to those that weren't able to?
Right, that's a very important point because not everybody has a relative or they can access these things. So from what we have found, that is more than 80% of the patients are able to do that. So we still run occasional, so probably monthly ones, face-to-face joint school, so they are not disadvantaged. So we started doing that as well. Once the social distancing that's all finished, we started doing face-to-face joint school as well. So, but we hope that over a period of time that will not be needed because most patients would be digitally empowered.
Absolutely, it's that transition period, isn't it?
Yes.
So my other question was, you spoke about the experiences which were very positive, and I think it was fantastic that you had a former patient in there that can dish the dirt, let's say, on the reality, which is the real drive at the moment, isn't it? It's so important for patients to access other person's views of the reality. Are you measuring and monitoring whether you had clinical improved outcomes at the moment from those patients? So they're doing the pre-work, they're learning about the exercises for the hips and knees, and you said that they were prepared for surgery. And are you seeing that in the recovery time?
We haven't quantified that because we don't have a baseline in that sense that so much changes have happened since COVID is it. But I can tell you that we've been doing day surgery hip and knee replacement Bangor, and this videos and information makes a huge difference because patients are knowledge is empowerment. They know exactly what's happening. From that, I can tell you, if you say you're doing a joint replacement going on a few hours, that's not going to happen because they know what's going to happen. That's made a big difference. So we're able to do that easily.
Yeah, absolutely. And obviously all of the exercises are really helping them. And I think the 11,000 views on the, as you said, the Fly on the Wall documentary is insight for the patient that they wouldn't have otherwise. So I'm going to ask the question, how did you convince the patient to be the fly on the wall? Were they quite willing?
They're actually quite happy because if you speak to the patient, they're, anything if it helps to the patient, that's what every patient tells. They're all happy if you're doing something to the betterment for other patients, they're always helpful.
Yeah, brilliant. And I think that's really important because we want to encourage more patients to come through and it really does have that impact. So you mentioned earlier that you'd really like to get this upstream now, so that you're using the card so that patients can, you know, find out a bit more earlier. What's the reception been like to that? Because sometimes we put people on a list and then they just wait until we call them in again.
Yes, the thing is that because the waiting time is so long, it's difficult to know what's happening. But one of the things you see, when we started first, that is after all the lockdown, there's a huge waiting list. And one of the main concerns was it'll happen like a complaining forum. Yeah, that was the worry we had. And surprisingly, actually, it happened to be like everybody felt that everybody's waiting, so I'm not the only one. It's actually, patients felt, okay, I'm not the only one. It was quite good. Patients were quite empathetic to each other, and they said, oh, I'm not as bad as the other person. That's how it worked. So it's like, you know, it's all positive, actually. It's been quite good.
Yeah, I particularly like the comment where somebody said that they'd asked questions, but then they other people asked questions they hadn't thought about, and how powerful that was as well. Because as clinical teams, it's very difficult to think about everything the patient might ask.
Yes. The thing is that I've attended initial few sessions. I don't attend them now. It's all done by the MDT team. But it's quite surprising how many questions patients ask. And personally, I think, you know, if you're in a sort of face-to-face environment, some patients are shy to ask questions. But I think with the virtual environment, it's almost like a level playing field. You don't see the patient next to you, but so you become confident. So that's surprising, actually. And the other thing is, the carer can be in a completely different place, in a different country, for example, and still take part in the care of their, you know, parent or whatever without taking time off. That's a huge advantage as well.
Yeah, absolutely. And I was going to come on to that. So I'm picking up work around value-based healthcare and sustainability nationally. So I was really pleased to see that you'd actually thought about the time travelled by the patient, and what that meant on our carbon footprint. So I think there'll be a lot of interest in your presentation and linking to those calculators, but really mindful that virtual gives us those opportunities as well to consider that impact of the travel and of the time. And as you say, with an elderly population, often with a family member or carer driving
it's a half day, essentially half day of work.
Yeah, absolutely. So on to the future. Obviously, we're talking about ideas and approaches on today's podcast about, you know, what can we learn and how can we do things better. What do you believe is the future of the work that you've been doing? Do you think it's scalable across Wales? You know, obviously other areas have the virtual clinics, but this digital approach. And do you think it could be spread across different specialties as well?
See, absolutely. One of the things was that if it is just passive online videos, it's like giving information, but the combination of the information provided and the explanation interactive nature, I think that's the way we should go. Otherwise, it's like, oh, my duty is just give information. It's up to you to read it. Then people don't necessarily do it. But now that you know there's a session, it's almost like it's an exam, isn't it? You have to watch it because somebody's going to ask, have you watched it? Isn't it? Otherwise, there's no sort of necessity to watch. And I think that's where I think all the information booklet, and we give loads of reams of paper, but whether it goes to the patient is difficult. But I think the interactive nature, because the advantage is that, say, even if you didn't watch it, after the interactive sessions, you see the other patient watched it and talked about it, you can go and watch it. You know what I mean?
That's it.
So it's a big win-win situation.
And it's a resource they can go back to, isn't it? It's, you know, it's not a leaflet that they've lost. It's not something that has been given to them at a time when they're recovering. It's something that they can self-pace and go back to on their own. And I think that's what's so magical about this with the scalability. So would you say that the videos that have been developed by yourselves and the teams at Betsy, are they exactly relevant to patients in an Iron Bevan? Do we need to be duplicating them, or do we?
Most of them are similar, but I think there'll be a little bit of a change. For example, now in Central, Betsy, they've developed their own videos. And I think also because you're going to meet those people. In the world, absolutely. It makes, it's better to have that local sort of a thing, you see, flavor, so that it's better. You know, there are lots of videos. There are a lot of American videos as well. You can watch it, but that doesn't give you that, you know, sort of a thing. Okay, it's ours. You know what I mean?
Yeah.
So it's not like the mentality of like regional thing and things like that. But I think it's yours. You're going to see the physio, same physio. So you meet the peers people who you are going to deal with that. I think that's good. It's not a big deal because they do that every time. I think the setting up the interactive session is very important. That's where we need to concentrate, I think.
Yeah, absolutely. I think those resources are fantastic, and I think it's really important what you were saying there about the building of the relationship with the local teams, potentially local dialects as well. You know, if we're delivering in different languages. So
we are actually in the process of doing Welsh version as well.
Yeah. Oh, but that's fantastic.
Yeah.
Well, I'd like to thank you very much for joining us today.
Yes.
I know that there may well be some questions when we play this live on the podcast. So if it's okay, if I can share those with you, or people can have your contact details, then we'll make sure they're available. But
thanks a lot.
Thank you very much for joining us today.
Thank you very much. Okay.
Bye-bye.
Bye. Bye.
So Dee, you had the benefit of a sneak preview on that, but I found that fascinating. Some of the stuff jumping out to me was the fact that just people don't have to drive, and your Cardiff's quite a tight, geographically quite a tight health board, but some of the other health boards in Wales are huge, so much more patient-centered, and 10,000 miles of traveling saved. That's incredible.
Yeah, absolutely. And I think, you know, when we were saying about the hours of the carers and family members as well, you know, because we do want to be there for our family members when they need us. We don't always know how long we're going to be waiting around, so it can be additional time off, and I think that would also be a really interesting aspect. But for me, it was a pleasure just learning what they've been doing up there, and the scalability options and opportunities are great. You could do it in your clinic, couldn't you, with local teams? And I think that local aspect is so interesting to build that relationship. And these days, it's as easy as a podcast to record ourselves doing that.
Yeah. And it's something I always found very interesting. You asked me about whether this was an option which could be scaled across Wales rather than duplicated in every health board. And I suppose we're always looking for examples of practice or models that could be applicable across Wales. Why reinvent the wheel? But I thought it was very interesting what Muthu said was that he and his team felt that there was definitely a value in still having some input from the team who would be delivering the care.
Yeah.
So I wonder, is there in models like this a sort of a middle ground for where you're certainly it's scalable and you're using some of the resources and approaches which could be used across Wales.
Yep.
But also retaining some of that local relevance, because I think probably as a patient, nobody wants just to pitch up and feel that they're just, you know, doing the mandatory training.
Yeah, absolutely. And I think, you know, the whole point about this was the benefit for the gains for the patient, wasn't it? And giving them a sense of what's to come, hearing from people who have the lived experience, meeting the people from their teams. And I think opportunities with digital give us that now. It's much easier to create videos and content. And there's always going to be some generic aspects, but if you're able to build in there what are the differences in your areas, people can come prepared. And it, you know, you can get some form of anxiety when you just receive a letter and then you turn up at an appointment. Patients are going to be much more informed about who's doing what they're going to be doing. And for me, it's also helping with their health literacy about their condition, you know, that preparation of what is going to happen to me, who's going to be doing what to me, where's that going to be happening. And I think it really, really fits with what Will was talking about last week with the 3 Ps, particularly the promote and prepare. So we actually give that power to the patients as well. It's not the clinicians waiting to come in and then repeating. And from what I gained from that as well was that the patients and the clinicians really liked the fact that it was a group and it wasn't a one-on-one, and there was value added that was gained from that, because we can't all think about the right questions at the right time.
Yeah, so it's actually better in some ways having a group of people all joining a session and contributing rather than a one-to-one with the clinician. Yeah. And I can see Gemma Jones from online has mentioned that the feedback from the patients is that they like to see the faces of the people who'll be caring for them when they come in for the surgery. So I think that's really important, isn't it? That people don't just feel they're receiving some anonymous online training.
Absolutely.
So was there anything else that you took from Move Through that you know, from that session, Dee, that really jumped out at you? Or because there's so much for me in that is very relevant to exactly what we're trying to do in outpatients.
Yeah, absolutely. I think there's been you know, a lot of innovative work being done around carousel clinics. So how do we get interdisciplinary teams together to help prep the patient and to understand? And this might actually be an easier method for us to do that for patients in those kind of virtual clinics and in the videos that can be used in those ways. Then maybe, you know, even traveling across one health board, let alone in areas where clinicians are traveling across health boards.
Yeah.
So I think there's an opportunity around our interdisciplinary working, and I actually think that could improve knowledge and understanding between those disciplines.
Okay.
In, you know, what do we all add for that one patient, but the patient gets it in a way that it's all comes together for them.
Yeah. Oh, great. What we're going to do next is go to a session that I recorded during the week with Claire Herlin. And Claire is the Strategic Head of Community and Chronic Conditions in Hywel Dda. And Claire's going to tell us about a project she's been involved with, and actually in collaboration with CumTAF. And before we start that session, I can see that we're being joined. We've got, I think, 60 people, 58, 60 people online today. From we've got representatives from every single health board in Wales, which is amazing, and quite a broad range of people, including members of the NHS exec. So really fantastic to see a good broad range of people joining us today. Before we start the session with Claire, I just have to apologise. There's a couple of points in the interview where the broadband, the Wi-Fi connection dropped out a little bit. So it's definitely not you, it's us, but bear with us, it's only temporary, and yeah, it corrects itself. So without further ado, we'll start the session with Claire.
Okay, so hi everyone, I'm Claire Herlin. I'm just going to tell you a story about how we looked at delivering spirometry slightly differently in Hywel Dda Health Board. So a few of us, Prof. Lewis, myself, and a couple of other people were talking about how do we get spirometry up and running again in Hywel Dda, because we know during COVID it was stopped because it was considered an aerosol generating procedure. And so we accrued a real big backlog. And we do know that if you don't do good spirometry, you can get misdiagnosis, particularly in COPD patients. And then that leads to issues like not getting the correct medication and people being misdiagnosed. So we were just generally chatting, and we've got some colleagues that we've worked with in the past in the pharmaceutical company. And they said we could bid for some money with some money so we just went online and I bid for some money and we got some money from them. And then Prof. Lewis and I had a conversation and said, Respiratory Innovation Wales were interested. We heard CumTAF were interested in trying to look at something different because they'd been doing some work on delivering spirometry on the weekends and that wasn't sort of getting through all the numbers. So we thought of a mobile unit in Hywel Dda because we're so remote, and we've got some areas where there's lots of people, some areas where there's very few people, and people don't like to travel in Hywel Dda. They like to have their care close to home, and that's the ethos of our health board. We're looking at care closer to home and trying to provide services that people don't have to travel. So through all those conversations, Respiratory Innovation Wales, Hywel Dda and CumTAF came together and agreed to deliver a mobile respiratory hub. And then all the challenges started. So there are lots of challenges when you're trying to deliver a mobile hub. One of them in particular was the moving of the hub. When do you move it? How often do you move it? So Louise Walby and I from CumTAF got together and talked about all that because it's around staffing as well. And where do you put it and how you're going to get the people to attend? Where will they come? What's the best place that you know that you're going to get mass impact and people will actually turn up for their appointments? So we just sat down and worked all through together. So we had to write lots of operating procedures, and little things like testing the water in the hub. I never thought about till we did this. Making sure the generator worked, who was going to turn the generator on, who was going to open up, who was going to clean. Infection prevention have real guidelines you've got to follow. Fire safety had to come in, and lots of things that we learned along the way, but eventually we got there. It was all signed off, and we agreed then every Wednesday the hub would move. So Louise and I talked about the staffing, and because we were going to ask staff that were already employed in the health board as part of their role to do the spirometry, we felt we couldn't ask them to give up a whole week. So if we moved it every Wednesday and then we had it Thursday, Friday, Monday, Tuesday, then they could plan 1 day or 2 days of their week into their daily working week. So hopefully it wouldn't have such an impact on all the other work they would have to do. So that's how we came about changing it from every Wednesday. We utilised staff in our own health boards, and they were band 6s and 7s mainly. So some of the learning from that going forward was that you most probably don't need band 6s and 7s to do spirometry, just to oversee, because we weren't actually reporting on the spirometry. What we were doing was doing the spirometry, writing a report of what we'd done, but not actually telling them what the outcome was and sending back to the primary care practice, because that was their job. Their job to call the patient in, do the review, look at the spirometry and talk to the patient. So we were just trying to get rid of the backlog for them so they could start afresh when it was agreed how they were going to deliver spirometry in primary care again. So what else did we do? So that took a lot of work, and where did we planning on where to put it? So we decided supermarkets would be probably our best bet, and they were actually really, really helpful. So some of the areas in Hywel Dda that we went to, so Asda in Pembroke Dock, Tesco's in Cardigan, we used the National Library car park in Aberystwyth, as well as Morrison's in Aberystwyth. We used Carmarthen, Tesco's, we used that Leeks car park in Cross Hands. That was particularly popular, and Parker Scarlett's car park. That was even more popular for the Nestle people. And we had a really good attendance rate, some sort of stats. In Hywel Dda, we had 1,487 referrals, and we managed to do 1,087 spirometries over roughly an 8-month period. So I thought that we all thought that was pretty good. Some learning from that, as I said, was that you don't need such qualified staff, but at the time we were using staff already, so we didn't have to fund extra staff to deliver. And also making sure you had enough staff on each day if anyone got sick or something happened. The generator was a bit of an issue because you only have one generator, and if that wouldn't start, you'd have to get somebody out. But the hub itself was fabulous. It was 2 Pantechnicon trucks put together. So we also had to think about, especially in Hywel Dda, the roads, and could you get them up the roads? And you had to think about car parks as well, because we thought of a few car parks, but we would never have got the trucks in the car parks. So with those sorts of things that I'd never thought about before, that you needed to think about going forward. And then we also thought about, could it be used for anything else? Spirometry. So we have a Lumen project in Hywel Dda, which is trying to capture people with lung cancer much earlier, and then so sponsored by Moondance, and it's usually all done by telephone. So they were struggling to get people to come in. So we actually advertised the Lumen project on Facebook and offered people to turn up in the hub as well, and the nurse would go there, and that doubled the number of people she saw by just turning up and delivering the Lumen project face to face. So that was a really good outcome for us as well. So we don't deliver the hub anymore, but we've learned from that, and we're just planning to deliver a similar sort of spirometry hub, but in a building with band 3 staff in the Llanelli cluster. So we've taken all our learning from that, and we're going to deliver another project and see how that goes over 2 years.
Oh, what a fantastic story. That's amazing, Claire. Claire, a couple of questions jumped out at me when you were describing that. And the first one is, when did you first recognize the problem, and what was the problem as you saw it before this all began?
The problem was that secondary care were being bombarded with spirometry, that we've never recognizing that we were seeing people in some of the service. We have an asthma interface team here, and we have community respiratory nurses. We were starting to see patients who were misdiagnosed and inappropriately treated, and a lot of it was down to the fact that they hadn't had spirometry in the first instance. And we also had a quick look at some of the data from the primary care audit, and it showed that only about 11% of people in primary care were actually getting gold standard spirometry, which was quite low.
Okay. And was that a new problem that began during COVID, or actually has this been a long-standing problem?
Yeah. So a little bit of a long-standing problem, because it depends on your practice, whether they deliver spirometry or not. So there's a lot of issues between the primary care, the national primary care team saying that it's an enhanced service and they should be paid for it. But locally, lots of practices want to deliver it. They feel that it's really important that their practice nurses have the opportunity to develop their roles and do spirometry. And as respiratory consultants, they believe that you can't diagnose it properly if you don't do spirometry as part of your review. It's not the be all and end all, but it's part of how you actually review a patient and come to the conclusion that it might be a restrictive disease, but it's really quite essential when you at that initial diagnosis.
Okay. And have you got a sense, now that you've run the project for some time, of the impact that's had in terms of the previous misdiagnoses and impact on care?
We did it's really difficult to get data out of primary care. So we have managed to look at a practice that's managed by the health board. And what we found from that was we looked at about 60 patients, and we found that having the right, about 2/3 were on the wrong inhalers. So we managed to pull them in. Luckily, we're very lucky. I've got some really good respiratory nurses who work with primary care, and we could pull them in and have a look at the data and pull the patients in and then change all their inhalers. Yeah, but there was a real impact in a couple of the managed practices that we managed to look at their data.
Right. And you mentioned that the model's changed a little bit now, so you're planning to use the sort of fixed sites in Llanelli. What was the reason why you decided actually not to continue the mobile hubs?
Cost more than anything else. At the time, it did its job, and we were given funding. But when you look, we could have run the hub in a better way. I think it's really changing people's hearts and minds, because people kept, if I'm honest, quite a few people kept coming to complaining on meetings I was at that there was nowhere to run their clinics or anything like this, not just respiratory. And I said to them, I've got this mobile hub, here it is, use it, come and ask me, we can set up clinic. No one did.
Yeah.
So whether it was inertia, and because they were so busy trying to catch up with post-COVID work and you can't see the wood for the trees, because that does happen, or they just couldn't see the benefit. I don't know, but you really, and it's interesting because now we've stopped it and it's been a little while. I got contacted by somebody asking about how do you run mobile clinics and things like that. And I'm thinking, why weren't, but you've got to, I've learned over the years that you've got to wait until people are ready.
Yeah, 100%, 100%. And it sounds like, that somebody's reaching out to you who's clearly an innovator, or you're an innovator. They've been an early adopter, and it's tricky finding those people sometimes, isn't it? In what's a very big system. So you obviously, how that covers quite a patch, doesn't it?
Big patch.
How far do people have to come for hospital clinics or spirometry? What's the furthest somebody might have to travel?
If
in
they, well, if they are, if they're needing to be seen in secondary care, it depends where they're referred to, but it could be a 25-mile trip one way. So
Okay.
if I could, we did previous to this, and I've talked about this, I think, in value-based healthcare, we did what we called our Viper project, where we looked at delivering pulmonary rehabilitation via hub and spoke model. So that we had a spoke model where we ran in a village hall, and it was streamed to the main hospital. And they could run the project together. So when we did that, and when we spoke to the people who did really well doing pulmonary rehab in the spoke model, they didn't care how much better they were. They would never travel the 25 miles each way to the hospital twice a week to do pulmonary rehab. So that was sort of, that project really started us thinking about, how can we, provide services closer to home. So some of our other services, like our community respiratory nurses and that, they all sort of do home visits and community clinics. So it's just something I think we've been building on for a long time, because we know that we can't always get people to come in. And I don't know, we've got some villagers even that just don't like to move out their village area. So how do you encourage them to come to clinics and make sure that they're well? Yeah. And that's a dilemma that I don't think we've still answered, but there are places where they just won't travel.
And as part of this work around, and essentially what this is it's dehospitalization, isn't it? It's moving services from hospitals out closer to home. Have you learned of or found other services across Wales who are trying to do the same thing, or who've done it successfully?
I haven't, to be honest, but one other area I work in is I manage all the self-management programs we deliver for chronic conditions, and all of that is out of hospital. So it's all delivered in village halls or community halls, and our courses are run there. And the two things that patients always tell us are the most important to them is car parking and toilets.
Yeah.
It doesn't matter whether how sick they are or whether they need to see someone. They get afterwards, or meet a friend. So it's a 96% attendance rate.
Oh, Claire, I lost
you, which is much better than anywhere else.
I lost you a little bit there. I lost you at car parks and toilets, and then I heard 96%. So,
all right.
So what's most important to people? Car parks and toilets. I can see that. And the 96%, was that around attendance rates?
Yes. Yeah. At the actual on the hub. Yeah.
So a 4% DNA.
Yeah, so the other thing that was on the hub, they could ring and leave messages, or they could ring in on the day. So, and we would swap appointments around if they said, I can't do 10 o'clock. So we'd swap it around to 3 o'clock and all that sort of thing. So they had quite good access to being able to contact us and make changes. And we had some really good outcomes from the patients. We did get some feedback from them, and lots of it was about the fact that the staff were lovely, and they, the test was done quickly and everyone was nice to them. So which is really important. One of them complained that we didn't have a lift, but we did have a lift. They just didn't know we had one.
And Claire, so it delivered the service it was designed to deliver. It was well received by patients. Can you tell me how the staff who worked in the hub felt about the work they were doing? Was this a challenging service to be part of for them, or did they enjoy being part of it?
They loved it. They really enjoyed doing it. I think also what we also did was, because spirometry hadn't been done for a long time and some practices were thinking of restarting, we offered practice nurses the opportunity to come in and do spirometry again under supervision of the specialist nurses, just to get them back and comfortable with doing it again. And we also had a few new members of staff, so we brought them in so they could start building their spirometry portfolio to get signed off to undertake spirometry. So we also used it as a learning hub at the same time.
Oh, fantastic. Well, Claire, I think we've nearly run out of time. So I just wanted to say on behalf of Dee and Nick and I and the whole team with the Value-Based Healthcast, thank you so much for taking the time to share your story. And I predict and I hope that when we do the session on Friday, there'll be some people very interested in reaching out and learning a bit more. So are you happy for people to contact you and get in touch?
Yeah, I'm the only Claire.Hurlan at Wales. The good thing about an unusual surname is there's only one of you.
Amen to that. Okay. So Claire, thanks so much. Lovely to meet you.
And you. Thanks a lot.
Bye.
Bye now.
So I really enjoyed that. Clearly somebody who's very passionate about the service they did. I just love the idea of a spirometry truck driving around Wales, parking in shopping centre car parks,
yep.
and bringing care to patients. But that was in some ways a joint effort between Halda and CumTAF where you work.
Yep.
So what was your experience of that particular service from the CumTAF perspective?
So yeah, it's definitely a joint project with Respiratory Innovation Wales, with Halda, ourselves, and Life Science Hub Wales, and really came out of the fact that, as Claire mentioned, GP practices were unable to undertake spirometry through COVID. So we were both experienced huge backlogs with no way of getting through them. So, you know, the number of referrals coming through, they were increasing. We were getting up to 1,000, 1,200. And Respiratory Innovation Wales were really keen to see how we could all work together in an innovative way. And the easiest way to describe the mobile respiratory unit is very much like the Breast Test Wales buses, just to give people a vision of what it was we were looking at, that we were working on. We had 2 of those joined together. And what we actually did was we came together as a project group with value leads, with the nurses. So unfortunately, Louise Walby, who's our lead nurse, is getting married. That's not an unfortunately, she's getting married, but she couldn't be here today because she's getting married.
Unfortunately for us.
Unfortunately for everybody else. But we had a fantastic team where everybody came together. So we really project mapped out everything. The Respiratory Innovation Wales were key on everything to do with the bus. So Claire mentioned the generator kept, might go down. So Rob, all hell Rob, would come out and fix all of the aspects. But it was more than that. It's all about the risk management. How do we get the equipment on the buses? How do we work out the rota for staff that are used to working in one hospital location where the patients come to them, and actually going in total to 16 different cluster areas? So where Claire said the bus would move, it would go to one cluster area in Haldar, move on the Wednesday up, and then a setup day, and then we'd start seeing patients in a cluster area in CTM. So very much like Haldar, the Tesco's, the Morrisons, but then also colleges, Macarthur Glen, fire stations, sports centres. So for me, a key bit was really working with our community areas about where could this massive bus go? How do the patients get there? Is it accessible? Is there parking? Claire mentioned there was a lift on there. It was very high tech, but it was very big as well. We got through very similar numbers of patients, I think, because we identified them both very similarly. So we used a partial booking approach where we'd be phoning patients 1 to 2 weeks before their appointment, and then they would come in when they could. So that worked really well. Both areas of staff would work early or stay a bit later if it meant patients could come. We had lots of people popping on the bus to see what was going on. So I think that, as Claire mentioned, there were lots of opportunities about what else could be done in this way once we've identified we could get out. The project did see a few months ago. Claire mentioned that there were national discussions going on about where spirometry would be held, and as we came to the end of the project, they were still being discussed. It's now been identified that spirometry will be coming back, will be with secondary care. And we've got a lot of learning from this project that we can actually use and share with others. So we work together as 2 health boards with respiratory leads and the National Respiratory Group with Dr. Simon Barry, and we did develop a PROM. There wasn't a patient-reported outcome measure that was available for this. So we developed the chronic respiratory questionnaire that was then signed off. So we've got that can be used by other areas, okay, which actually measured the functional status, the health-related mobility, but also aspects of quality of life like anxiety and depression. So having that information in quite real time meant that we were able to pick up those issues while we were on the bus as well.
Okay.
And we did use the PREM. So there's a number of learning opportunities that we could share.
Fantastic. And one of the things that we've always been really interested in on the Value-Based Healthcast is not just good ideas and what works, but also how people got things to work.
Yeah.
And this sounds like a very complex problem in terms of it was 2 health boards. There was a couple of different funding streams. There was the health board funding stream. There was, I believe, some commercial funding as well.
Yeah.
There was some oversight from Respiratory Health Wales as well. So what made it work?
One was absolutely the passion of the clinical teams. I think having Respiratory Innovation Wales definitely gave us that innovation viewpoint of what could we achieve and how do we get this bus and how do we make it work and how on earth do we try and move it between 2 very big areas. The project management support provided by Life Sciences Hub Wales meant that the health board themselves could really work on the clinical aspects, on things like the PROMs, the PREMs, how do we get patients in. In CTM, we did have a physiologist interpreting results before they went back to GPs. Right. So we were trying to lift as much as we could off. But we all brought different aspects to the project and then came together and actually delivered it, which is what we wouldn't have been able to do this as one health board alone. We wouldn't have been able to do it through cost. And actually we were able to share the load on all of the work, even things like setting up the PROM on the computer and making sure it was loaded. We were able to just share everything, which was fantastic.
Oh, fantastic. So just a reminder that there's a couple of comments which I'll come to, but if you do have any questions for Dee or any questions for either Muthu or Claire, please pop them in the chat bar, because although Muthu and Claire aren't on the call today, they've committed to answering any questions you might have. So I've just come to a comment from Heather Braid, who's in Cardiff and Vale, and this is regarding carousel clinic. So I think one of the questions was, what is a carousel clinic? And that's where you have one patient, but they're attending a range of consultations in one go, aren't they? Yes. So there's a couple of different professionals there. And Heather was mentioning how that's how adult cystic fibrosis clinics are run. And particularly in pediatrics, I'm a pediatrician by background, there's many children with complex needs who need care to be delivered in exactly the same way.
Yeah, absolutely.
And then John Morgan, mentioning that in Power, something similar to this was done with mobile spirometry and sort of drive-in spirometry to get around the aerosol generating procedures issue. And as well, they worked out the patient miles saved, comparing using the mobile spirometry to the nearest DGH, and they saved a total patient miles of over 6,500, averaging 44.9 miles per patient. So really big in terms of patient convenience, patient-centered care, but also carbon and diesel in the environment as well.
Absolutely. I looked very similarly at the data in the Bridgend area, so where we had MacArthur Glen, and for the 247 patients that we saw from that area, we saved 10,000 miles that they would have driven to their local hospital area. So I think from a value point of view, thinking about some of these metrics, and it goes back to all of our projects today, in thinking wider of the value that what we're doing is creating. So bringing people together, the CO2, the time, all of those things are all added extras in the value of doing something different.
Yeah, very much so. And then finally, so Ravi Chana has mentioned about what a big element it is, the resilience needed to see these types of projects to completion. And you mentioned the project management support, because it's a huge transformational project, isn't it, doing something like this? And actually there's a massive amount of energy and time and investment that goes into actually just making it happen, apart from delivering it. So I think that will resonate, I'm sure, with anybody who's tried to do transformation on either a big or a small scale in healthcare.
Yeah, absolutely. And actually that area of resilience is really important, because we want to create value for all of the partners that are involved. Respiratory Innovation Wales wanted to be able to test and support innovative practice. The health boards, wanted to make sure that our patients were being seen and treated and diagnosed. And the hub is really keen on how we all work together to do that. So, one of the things we did up front was, what's everyone want to achieve? And at the centre of it was that people were getting what they needed as soon as they could. But that does lead us very nicely into sort of section 3, part 3 of these, where how do you do this? How do you get people together? How do you know what people really want to be thinking about? So our third part next week will really be next month, guys, 24th of November, is going to be an interactive session on, okay, where do we start? What do we need to do? And we'll have some short sort of videos from some of the wide ranging experts that really come together in value-based healthcare projects as well. So what do finance do? What do the data guys do? How do you even find a PROM and a PREM, let alone implement it and analyze that data? And how does that work with clinical teams? So I think that the next session will be really interesting for people to come on an interactive journey with us.
Indeed. Right. Well, from Dee and I, and from all of the team behind the Value-Based Healthcast and Professor Sally Lewis and the Wales Value and Health team, just want to say thank you very much for joining us today. If you do have any questions, please do reach out. We'll put the recording on the YouTube channel shortly. But thanks for joining us today.
Thank you. See you soon.
Bye.